should stop talking so I can go to nap, right? That's thalamus. And so the brain does not hurt, that's what we think, but it activates the periphery, the thalamus does, to cause you pain. Now, there are things that will, like a lot of my patients say, I don't want my thalamus. Yes, you do want your thalamus. If you have thalamus damage, like stroke, then you're going to have nonstop pain in half of your body, wherever the thalamus is damaged, nonstop. So you want really well-functioning thalamus. And so what do you want to do for your thalamus? That's why you want to give it a good nutrition and enough sleep, and you don't want to stress. Now, it turns out that a lot of medications, such as Tylenol, Excedrin, ibuprofen, narcotics, if you start taking them more than 5 to 8 days per month, they can actually cause dysfunction of the thalamus and can cause you more headaches. Okay, so that's a very common thing we deal at the University of Washington. People think, well, it's over the counter, right? It should be safe. Well, depends. If you're prone to headaches, not so much. But safe. Under 4 days, probably okay. If you start inching over 4 days a month, so need to be aware of that. That's a very common issue. So then the thalamus, if it decides, okay, you have been taking too much thalamus and you had the good chocolate and wine and whatever, says too much, I'm going to cause the person a headache. They're low on energy, and it activates the nerve, the neck nerves, to cause neurotransmitters, chemicals. And you've heard before the talk on in the autonomic nervous system. And if what are the chemicals? So, and this is very simplified. It's probably much more complicated in our brains, but we have serotonin. Have you guys heard of serotonin? So raise your hand if you heard of your serotonin. Okay, so everybody has heard of it. Endorphins, norepinephrine, so I'll tell you how to increase those. Those are the chemicals you want to increase if you don't want to have much pain. And then you have the propane system, and that's where many medications work, but some of those chemicals, so this picture is neurons talking together, so 3 neurons, and the one neuron from the top is releasing the anti-pain chemicals, the other one propane, and then the final neuron decides like, okay, what's going on here? So the propane chemicals are glutamate, you might have heard of that, CGRP, substance P, it stands for substance pain, I don't know how they named it, they had probably a lot of fun. So now, the norepinephrine there on this first slide, it's the anti-pain, right? Because it's serotonin, norepinephrine, endorphins. And so it turns out that noradrenaline, norepinephrine, is a sympathetic neurotransmitter, and when you feel stressed, you deplete it. And mostly if you have prolonged stress, you deplete it. If you deplete it, that's when you're going to have not only more pain, but more of the autonomic symptoms, like feeling more lightheaded and dizzy, because it's a major neurotransmitter for the sympathetic nervous system. So you can test it by giving people this medication called phenylephrine. If someone gave you, it's done only experimentally, you really don't want this. And experimentally, if someone has migraines and you give them the phenylephrine, you'll increase their blood pressure, and the blood pressure will stay increased for much longer than people who don't have headaches, and much higher. And so currently, there is this idea that in some people, their nerve receptors are extremely sensitive to their neurotransmitters. So it's not a change of structure, but of the function of the neurotransmitters. They're just really sensitive. In people who have proneness to fainting, the neurotransmitters, we think, and the receptors get even more sensitive. So failure or fainting spells imply very significant failing of the system. Any of us can faint if we get into a situation where we get hypoperfusion of our brain. It's our protective system. And so there is something called syncopal migraine. So it turns out many people who don't have any structural problem with their autonomic nervous system still can faint and have migraines both. Now, if you compare, so you have these boxes to compare, what does it look like in pure autonomic failure versus multiple system atrophy, MSA, versus migraine, and syncope is the fainting spells. So the potential, if you weren't in a wheelchair, right, if you were standing upright and you had MSA, up to 40% of people or 45% of people could faint. Okay, it's pretty high. Dizziness, you can see, is extremely high in migraines, multiple system atrophy, and pure autonomic failure. So is the neck pain. If you look at the neck pain, that's the main pain that is really high up on the list of the pain that people with MSA, Parkinson's suffer. And if you say, again, what is contributing to it? Well, the autonomic nervous system not allowing you to be easily upright, but also probably, sitting then in the wheelchair, right, not being able to be as active. So it contributes to that, and also visual disturbances. So pupils are another way to assess the autonomic nervous system, and they don't function as well when you're prone to both headaches, but also in these disorders. So orthostatic hypotension is much more common in people who have migraines, but also that's how you diagnose also with someone who would have pure autonomic failure or MSA. So migraine is so common, and then if you get on top of that MSA, you're going to be much more prone to getting into neck pain, but also whole body pain. You're just going to have receptors that are much more sensitive. And again, what plays a role? Probably, why is it different from person to person? Genetics and environment, right? All of us, react differently. So in MSA and pure autonomic, is the autonomic absence, right? The degeneration of the system. In migraine, doesn't have to be just function, but you can have both, combination of both. And I think that's what makes it much more complicated. So what happens, we think, prior to the headache, you decrease your norepinephrine, serotonin, and the other neurotransmitters like prostaglandins, those cause pain, adenosine increase. So on this slide I have, if people feel nauseated, a lot of times it could be related to the dopamine levels. If you have pain, it could be the prostaglandins. If you feel sleepy, there could be adenosine. That's why coffee decreases your levels of adenosine. That's why people like to drink coffee, in the afternoon to decrease their adenosine. And that's why people sometimes like it with headache as well. And lack of norepinephrine can lead you to have then the ptosis and feeling dizzy and lightheaded and feeling like you're going to faint. So stress depletes the system and can cause more migraine, but it's not the only piece of the story. So coming to the neurotransmitters, I promised that I would talk about how can you actually improve your systems. And I'm going to get to this slide later. So what we first start with is making sure there are no other contributing factors that are causing you headaches. I've talked about Tylenol, ibuprofen, Excedrin can unfortunately worsen your headaches. Alcohol, again, small amount probably okay, but beer, wine can certainly increase headaches so much. Also excessive caffeine. So we're concentrating, we call it multimodal treatment, meaning that you need to address multiple factors to feel better. And one of them is preventive daily medications. Now, medications by themselves, so they have done studies where you have one group of people with headaches and they take medications every day versus another group of people who exercise every day versus another group would say, okay, you guys just relax for an hour every day. And you compare the three groups, so medication versus exercise versus relaxation in 3 months. And guess which group does the best? Everybody's saying exercise. Well, everybody does the same. So they all improve about 20% or so. So what does that mean? That means that it's good to have exercise and relaxation and maybe medication as well. So combination, what they call multimodal therapy, is the most effective. Now, prophylactic medications, again, can help you maybe 20-30%. And the idea is if they can help you feel a little better, so then you can do more exercise and relaxation and not feel as bad. The problem with them, they have to be taken every single day. And this is where I have complained of patients that go, really, I have to take this every day? Yes, you have to take it every single day, and it takes a long time to see the weeks to even see if it's effective. If you patients. Now, are beta blockers. Beta blockers decrease the perception of when you feel stressed and can be very helpful. They're FDA approved for treatment of headaches. Amitriptyline and nortriptyline you heard about. Those are especially used if you have difficulty with sleep or as you heard talk if someone has diarrhea. They basically calm down the whole system. They work about 7 different other receptors, so they can have super effective. They can help with sleep, help people feel better. Now, however, they will not work if you don't work on increasing your serotonin level, and we'll talk about how to do that, because all they do is serotonin reuptake. They just increase the levels that you make. Now, one of the most popular drugs in the coming and saying, this is what I want, is Topamax, topiramate. And if you say, why? If you say, why is it called a supermodel drug? It's the only drug that causes weight loss. Everything else in neurology that is everyday, daily, either go now, but you have to be careful because you don't want to give them this drug. Side effect is it can cause problems with spelling. So my joke is I have friends who are supermodels and they just can put X for their signature, right? No offense. So they don't need to spell. But it can cause spelling. It can also very, very rarely cause kidney stones if you get dehydrated. So you really need to hydrate with this drug. Now, Celexa citalopram is a serotonin reuptake. So again, if you say, what does this mean, the serotonin reuptake? You keep referring to it. All it does, it decreases degradation. That if you wanted to, let's say, have something in the fridge, like chocolate cake, and you don't want to eat it, you put a lock there on the fridge. If you didn't make enough serotonin, so then it makes sense to take amitriptyline or Celexa citalopram. So this is where you want to pay attention. All of you who have been sleeping and taking a nap, this is when I'm going to wake you up. Okay, so early morning sunlight, it does not cross the window. Very short wave sunlight. It's not the warm light. Early morning can activate your eye retina. So you have about 42 different neurons in the retina. It's a magic number, right, John? This then gets through to the pineal gland, the part in the brain that converts the food you eat, the protein, with the help of B vitamins. So magnesium is one of the medications you can use to decrease headaches, neck pain, stress. It was actually studied against placebo for headaches, and it decreases the muscle spasm, neck pain. And a lot of times if you can't swallow, they have powder. It's called magnesium calm. Now, the other thing that it would help you for is if you're prone to constipation. It will clear your gut, no problem. If you're prone to diarrhea, not a very good idea to take magnesium. Okay, so it's for people who are prone to slowing down, have constipation. So then you can treat your constipation, right? Muscle spasm and migraine with one drug, and it can make you more relaxed. So this is what we commonly use for pregnant women because it's super safe. B vitamins. You know how I was telling you that how do you make the serotonin going outside? To convert the protein. When you hear from your neurologist that you should B12, B2, but all the Bs, you need them. You can take them from food. You don't have to just take supplements. They can be extremely helpful to, again, increase the levels of the serotonin and brain energy. CoQ10 you've heard of. This is where Dr. Sami talked about it, when I was training in residency, he would put all the patients with Parkinson's and MSA on CoQ10. Now the studies are not as clear. However, it has been studied for headaches, and it turns out if you take 100 milligrams 3 times a day, you do have at least up to 50% decrease in your headaches. It increases the mitochondrial, your energy power of the cells, so they produce more energy, so you don't feel as drained. It's very safe. It's, as Dr. Sami said, it's really expensive though, so you have to be kind of mindful. Do I really like magnesium? It's cheap. CoQ10, a little bit higher, up. The feverfew tea is another one that we use to decrease pain. That is very, very, because I told you, okay, Tylenol, Excedrin, ibuprofen, not a very good idea if you want to take it every day. You're going to have more pain. So feverfew tea has been studied. It has been available since Greek days. It has been studied for headaches, decreases headaches up to 50% compared to placebo. Very safe. And this is a brand flavor. So that's one of my patients brought it to me. I learned from my patients all the time. I said, you know, doctor, the feverfew you recommend, it tastes horrible, but this brand is fantastic. It tastes great, and I don't have headaches. I said, good, I'll share it with other people. So you can find that. Now, SAMI is another supplement that can boost the serotonin levels. As you can see there, it's especially used if you feel tired, low energy, headaches, you know, feel like my brain is not working. I've taken it in the past. Melatonin is another supplement for people who can't sleep. This has been studied for migraines. It's very safe. It can help you with your sleep. It can also improve mood function. So what if you continue having headaches in spite of all of this? What are the other options that you have? So this is what people come to me. Have you heard of Cephali? I said, yes, I have. It's FDA approved for migraines. However, it's not insurance covered. It's about $400. And it's for people who don't want to take daily medications, who don't, it's something that I would Google, chair yoga, but certainly that might be if you can have someone help you get into the pool, right? Then the water will hold you so you're not going to fall, right, and get in trouble. The problem is safety of getting in and out of the pool. But if you can do that, that can be very helpful because then you don't have to worry about, you know, fainting or falling, and the water will hold you and help you. Now, of course, importance is to have friends, right? There's no question about that. And I'm going to stay the last slide that I think that the key for all of you guys here is that you have amazing support. So I want to thank all the caregivers here, along with all the patients, you know, and the providers who are here, because I think that that's what is the key towards healing, is feeling that you're not alone, that you have everybody around you who cares about you, who brought you here, right? And vice versa. We're here to support you as well. So thank you very much. Am I taking, I think I'm taking questions at the end, right? Yeah. And I didn't tell you, the disclosure is that my husband is going to be talking next. He's a psychiatrist, and that's my joke. That's why I'm so normal, you know, because I'm married to a psychiatrist. So, yeah. Did you guys have fun while he's getting ready? Yes. Okay. At the end of the talk, that's what they just told me. So please write it down, and I'll answer them.
Okay. It looks like we're going to kind of have a little flip-flop here in the schedule, and Dr. Krashen is going to, is that the way you pronounce it, Krashen? Is going to give our next presentation, and then we'll just keep moving on down the agenda. So while he's going to the podium, though, before I forget it, because I forgot it earlier, we have DVDs of last year's conference. They're free. They're out on our table. So on your way out, don't forget to stop and get one of those if you don't already have one. Thanks.
Hi, I'm Dr. Krashen. Can everybody hear okay? I don't usually use handheld mics except in karaoke, so just let me know if it's drifting too much, okay? Louder. Okay. Okay. I'm Dr. Krashen. I'm one of the psychiatrists at University of Washington, work at Harborview Hospital, and I'm also an attending in the pain clinic there at Harborview, and also the direct... Okay. Okay. All right. Is this better? Okay. And so I have no conflicts of interest. Talking about the autonomic nervous system, I think we've already heard a lot about that today, so I won't belabor it, saying that it is a really widespread system, affects all kinds of organs, a lot of which organ systems we've already been talking about today with other lectures about the lungs and the heart and the eye. And what I'm going to be talking about more is the central nervous system, specifically the brain. But I think it's helpful to look at those autonomic nervous system just really briefly from what we call a behavioral standpoint, because the same things that we talk about with systems which will turn your digestion on or off and make you eat, get you ready to digest or get you ready to do something else. They also have a behavioral purpose. The body uses the same nervous system for multiple functions. And so the sympathetic system does many, many things, but one of the easy ways to think about it is the fight or flight system. So I have a picture here of a gentleman running from a hippo. And so if you're walking here in downtown Seattle and a hippo comes around the corner and you gotta make a break for it, or if someone suddenly cuts you off when you're driving to the airport, which is more likely, then you'll get that fight or flight reaction, which people know what that feels like. It's, the heart goes faster. They might feel a sweat. They might feel their hair stand on end. All those things. The parasympathetic is, at least when it comes to behavior and attention, is kind of the opposite. It's the rest or digest system. So it's the system which helps us relax and helps us calm back down. What's important to notice there's the comment at the bottom there that the sympathetic nervous system is basically a highly sensitive system. It fires off and then it activates the whole system. Okay, I'm sorry, it's not working very well. Okay. Is this working any better? Like this? Okay. Okay. So the sympathetic system, just go back, that's the fight or flight system, and that's a quick response system. The idea is that when you perceive something which is risky, your whole body reacts just like that. Parasympathetic, that's more of a slow system that takes a while to kick in, and then it calms down a lot of the body's reactions, gets you ready to settle down on the couch or in a chair or whatever, to rest, to digest, think about things. And often what we find in modern society is that people have kind of an imbalance where they spend a lot more time with their sympathetic system getting triggered because they have things happening, exciting videos, bad traffic, all kinds of things that increase their stress. And that system fires off very easily and fires off throughout the whole body. The parasympathetic system doesn't activate as easily, and it doesn't go as quickly. The autonomic system, in addition to that, it also affects behavior. So it'll, in more subtle ways, it'll influence your mood and how readily you're able to respond to things around you, whether you feel like responding or not. And it's complicated. As this shows the sympathetic nervous system, I think we've actually seen a very similar slides today already. It covers all parts of the body. And it's actually kind of difficult to tease out with something like if someone is ready to sort of get up and do something, and if they're having trouble doing that, where is the problem there? It could be at multiple places here, that maybe the sympathetic nervous system is not doing its job in the brain to get that person ready to do that task, or it could be something with the heart, that the heart is not responding as well, and so it's not giving them the energy they need. There's lots of different areas, and that makes understanding this in the people who have autonomic nervous system disorders more complicated. I want to drill down a little bit into the autonomic nervous system and the basically the adrenaline system. That's another way of calling the sympathetic nervous system, that the locus coeruleus. That's the little spot there that we see in the brainstem that there's the arrow going to. That's really the start of the stress response. You could call it like the brain's panic button. When something happens, which we the boss releases adrenaline, which is also known as norepinephrine, into the amygdala. And the amygdala is basically, I like to think of it as, amygdala means almond, but I like to think of it as the scared cat of the brain. If you've ever seen a cat which is freaked out about something, you'll see it arches its back and all of its hair stands up and it yowls. And that's sort of what the amygdala does for us. If it when it gets activated, and then it sends messages out to many other parts of the body, including the hypothalamus, and affects the whole autonomic nervous system, and that's really what triggers that sympathetic nervous system that goes down through the whole body from there. From analysis, it doesn't really matter so much if someone is having a sort of a surge of sympathetic activity, if that's coming from a chemical. For example, a doctor just injected something like phenylephrine into your bloodstream, or if you're having that chemical surge because of a piece of bad news you just got or something like that. It actually acts very much the same way with this whole body reaction that is both in the mind with things like fear and anxiety, and also in the body with arousal, which is basically getting ready for action. This leads to stress. So here we can see this is what we call the HPA axis, and that HPA stands for hypothalamus, pituitary, and adrenal glands. So at the top there on the brain, you can see the hypothalamus that activates the pituitary gland, which is kind of the master gland that regulates all the other glands, and that affects the adrenal glands, which sit on top of the kidneys and produce cortisol, the stress hormone. That system is designed to turn on and off sort of briefly and intensely. So again, when you get the call from your boss or the hippo, that it's designed to turn on briefly, deal with the problem, and then turn back off. And what happens is when you have chronic stress is that this system is getting turned on for long periods of time, and that system gets overactivated, it stays on, and you're getting higher and higher levels of cortisol, which is a stress hormone. And that actually degrades your brain's ability to react to stress over time. I'm not going to explain this whole slide. It goes way beyond it, but just showing that the interconnections are extremely complex, and there's a whole lot in the prefrontal cortex. That's the area that sits above our eyes and helps us with things like planning and making decisions and switching tasks. For example, saying, this is taking too long, I'm going to do something else now. This is a good time to make that phone call that I need to make before 4 o'clock today. Your prefrontal cortex is intimately involved in that. And the function of that, and if the adrenergic tone is too high, then the performance of that goes way down. And in fact, there's something that's been known for about 60 years now, that there's kind of what we call an inverted U curve of stress with performance on most tasks, where if you give people a little bit of stress, or they do better on a task. If they have no stress whatsoever, if they're kind of sitting in a beach chair in Cabo San Lucas, their performance is not very good and they don't get a whole lot done. But if they get too much stress, then that really high stress level, the high cortisol, the high sympathetic tone, that actually interferes with being able to do stuff. And people kind of seize up, they break down, they're not able to function well. So there's actually a good amount of stress. Anybody who's ever tried to plan a wedding knows what that's like. And they know that there's times when it's manageable and times when things just seem to be totally chaotic. So why don't zebras with stress, why don't they actually do this? Why don't they have stress and lose the stripes? And it's because, zebras don't plan weddings. Zebras don't worry about things like possibly losing their job or chronic illness or anything like that. What they mainly worry about are lions and cheetahs. And so when a cheetah comes at you, you run away, and it doesn't take very long to find out whether you made it or not. If you didn't make it, then you don't have anything to worry about. And if you did get away, you don't have anything to worry about, and you can settle down and start eating grass again. That's life as a zebra, and it's a lot simpler. It's a lot simpler than life in the modern world. But these systems I've been talking about are not all that different. They've been around throughout the whole mammalian kingdom, and so we have the same reactions that zebras do, and if you have a dog or cat at home, they have all the same systems we do. And so they work the same way. And they're really they're very good for getting us away from hippos and cheetahs, and they're not so good for dealing with chronic stress. And a big part of a chronic illness is chronic stress, and so that's something that's important to keep in mind. It causes all kinds of problems and really raises the risk of mood disorders. And you can see here's the chronic overactivation of the system leading to the fear reaction. And that fear reaction is not just being scared of specific things, but a chronic overactivation where people will have a tendency to feel dis-ease all the time and have very strong reaction to any new things that are coming in, and sometimes even to see threats where there may not be any. And what this chronic stress syndrome, as you might call it, it's complex. It can cause a lot of physical symptoms, and here this is not. And you see there's a lot of overlap here with the same problems that autonomic nervous disorders can cause. So there's a lot of overlap there, and people who already have some neurological conditions, they're going to be more sensitive to all those things. And part of what I think mental health and psychiatry can offer in a neurological clinic is helping tease out some of these things and figuring out, for example, if some of these physical symptoms may be stress-related or related to something like depression, and that if we're able to address those things, we may be able to get people functioning better without, even if we're not able to change any underlying illness process that's going on. Here's just an example of when I'm talking about where it's very simple. What we're doing is very simplified. So the brain has many different regions, and those regions all correspond to different aspects of our behavior and our physical functioning. Again, I'm not going to go into this whole slide. It's in your slide set that you guys got. If you want to look at explaining about how things like fatigue and pain are all related to dysfunction in different areas of the brain. But what I'm talking about really is how there's a hardware problem that goes on MSA. There's also a hardware problem that can happen in depression. But a lot of things with depression and stress can better be thought of as software problems, that if you can change the programming in the computer will work better, and you don't necessarily need to get a brand new one. You can keep working with it. And the same thing with the brain. If you can change the program with things like therapy and medications, you can get things working a lot better, even though we don't know how to change the hardware yet. Here are the two most important transmitters for the autonomic nervous system: noradrenaline, that's the stress response hormone, and acetylcholine, which does many, many different things. I wouldn't call acetylcholine just the parasympathetic neurotransmitter, because it does so many other things. It's deeply involved in memory and other things as well. But what that means is that medications which affect either of these can be therapeutic, but they can also be responsible for a lot of medications. And earlier on, Dr. Zia was talking about how some of the nice drugs they use for GI complaints can also cause a lot of neurological issues. And that's really true, and that's also very true of psychiatric issues. And unfortunately, because neurology and psychiatry, they were actually the same field not that long ago, about 100 years ago, they were exactly the same field. And all the psychiatrists were also neurologists, and we still share the same licensing board. So a lot of the medications that we use in psychiatry overlap with those in neurology, and a lot of them will have side effects because they directly affect the nerves. This is just briefly talking about heart rate variability. That's a measure of autonomic nervous system function. This has been shown this variability is one of the measures of a healthy autonomic nervous system, and it's decreased in MSA, it's decreased in a lot of other conditions as well, and it's also decreased by stress. So if people have decreased heart rate variability, that can be a marker that they're at a higher risk for heart disease, and treating that, for example, by stimulating the vagal nerve, can actually treat depression. One of the ways that we try to measure this and treat it is with biofeedback, and there's actually a gadget from a company called HeartMath that will measure your heart rate variability, just subtle changes in it. And what's very interesting is then if someone does meditation and they relax, their heart rate variability will improve because their autonomic system is basically sort of relaxing and functioning better. And there's about a 40% rate of depression with people with autonomic dysfunction, especially MSA. There's a very high association. I think it's what we'd call multifactorial. That some of that is because of all the real-world difficulties that are presented by it, and I think there's also a direct biological connection too, with that autonomic dysfunction. Then it's tinkering with some of the most basic things that the brain uses to control our behavior. This is a patient with MSA in England with her daughter. I saw this that she has a very moving story about her struggles with her medical issues and her depression. There are a lot of psychiatric medicines that can affect the autonomic nervous system, and it's important. And I think if a doctor is prescribing them, or if you're going to be getting these medications, it's a good idea to watch out for this because people can be much more sensitive. So the nortriptyline and propranolol, those are good examples of some of the most common medicines we'll use for depression, for anxiety, also medications used for PTSD. A lot of these work by affecting the adrenaline, by blocking it and then decreasing people's feelings of anxiety. And also there are a lot of antidepressants that will block these not as part of their main action, but as a side effect. And especially if anytime you see a medication and you see in the warning label that it can cause dizziness or dry mouth, that would be a good time to then talk to the doctor about whether this is something that would be safe and at what dosage. And it's almost always a good idea to start low and go slow. That's a good advice almost any time with psychiatric medicines anyway. A couple of the medicines that are pretty reliable and well tolerated are the SSRIs, for example, Celexa, citalopram, and then the newer generation of SNRIs such as Cymbalta, which Dr. Morinova also talked about for headaches. Those are generally quite safe and well tolerated, although it is a good idea to start lower with them. This isn't in your slide. Isn't in the slide packet, but this is a newer treatment which I think could be quite promising called transcranial magnetic stimulation. And what this uses is that you lay in a couch, a little bit like a dentist chair, and they put a magnetic coil on your head and stimulate the left side of your forehead for about 40 minutes, 5 times a week. So it requires you to come into the clinic pretty frequently. But it's actually quite helpful for people who are depressed and haven't responded well to medications. So we certainly would not recommend that people that people do this if they're just depressed and they haven't tried other things. But if you have tried other things, about a third of patients overall will not respond to medications as well. And it's certainly worth trying this. It's very safe. It's not contraindicated with most medical issues. And there's some suggestion that after getting it, people respond better to medications too. Another issue which is not directly related to mood disorders, but can look like it is what's called pseudobulbar affect. And this is the picture of the clowns at the funeral. It kind of symbolizes that it can seem really inappropriate and distressing to people. Some people may have seen ads for this drug, Nuedexta, where basically the idea is that people have dysregulation of the part of the brain which controls affective expression, where people can have brief episodes of crying or laughing. Crying is more common from the literature, and sometimes that can be brought on by a stress, or even something like a sad scene, a TV show, or a sad song on the radio, or sometimes kind of out of the blue, just a surprise will cause this emotional reaction. It can be unpleasant for people. It's embarrassing. People who don't know you well may take it at face value and say, "Why are you laughing? Why are you laughing at that bad news? That's really rude." There is a medication which has been approved for that, dextromethorphan with quinidine. Some people also find that antidepressants or mood stabilizers, which are usually anti-epileptic medications, can be helpful for that too. we've talked a lot today about the dopamine agonists, things like levodopa. There is an association that because dopamine is another of those chemicals that does many different things in the brain. So it's deeply involved in movement. It's also involved as a pleasure chemical. And there have been case reports, and it's well established that some people who are taking levodopa, for example, but also other dopamine type boosters, that they'll suddenly develop sort of an addiction to pleasurable things, even if this was not part of their personality before. It's a drug side effect, but it could be pretty devastating. So the picture here is of a guy passing out in front of a lot of playing cards, and that's because some people have developed pathological gambling after taking things like levodopa or some of these other, or pramipexole, these other dopamine boosters, because basically they suddenly are these things that boost dopamine, suddenly they've sort of sensitized their pleasure centers, so they just get much more enjoyment out of these things, and they become addictive in a way they weren't before, so that people can have real behavior changes. That's actually less common in MSA than it is in other conditions like Parkinson's from the literature, but that it has been reported. It's something to watch out for. And then fatigue and apathy. These can be really easily confused with depression, but there are patients who will say that they are not feeling particularly depressed, but they do feel tired, or they just feel apathetic, unengaged. Fatigue is something I work with in the chronic fatigue clinic, and it's something which it has many important if someone is really feeling fatigued to really sort of look for other causes of things before you just decide it's just plain fatigue. Make sure they don't have an infection somewhere, that they're not having a side effect to a medication, see if they're not sleeping well, see how they're eating, all those things. But autonomic disorders are very strongly associated with fatigue, and part of that is because that fight or flight syndrome reaction that we have, that's also needed just to kind of get up and get doing things, not just in terms of keeping your blood pressure high, but also to get you ready to take on a new task. And if you don't have that response to your body, it just feels like you're wearing lead overshoes. You just can't get going. Sometimes and I've seen people who have autonomic disorders who came to the chronic fatigue clinic, and nobody had picked up on it because the patient didn't really complain much of dizziness. They said, "Yeah, I'm a little dizzy, but it's really the fatigue that's killing me, doctor." And then I've sent some of those patients to Dr. Oakley. So you want to address those other things first, but if those other things are addressed and the person is still very fatigued, then there are medications that have been shown to be helpful for that, particularly psychostimulants, and a drug called modafinil or Provigil. It was originally developed for modafinil was originally developed for treating narcolepsy. It's kind of an anti-sleepiness drug, but some people find it really helpful for fatigue as well, and I found it to be helpful for that. It may be difficult to find a doctor willing to prescribe or address fatigue, but I think fatigue is pretty important, because if you're physically able to do stuff, but you're just too tired to do it, then your quality of life won't be very good. And then I'd be remiss in not talking about the non-pharmacological treatments. So exercise, I think Dr. Muranova did a really good job of talking about all the benefits of exercise. And so I'm just going to mention that briefly, that exercise is kind of good for everything. It's a very powerful antidepressant. It's good. It's very good for fatigue. And the trick usually is pacing yourself, building up your stamina. So because, especially exercise for fatigue, if you do too much too soon, it'll make you more fatigued. Psychotherapy, and especially cognitive behavioral therapy, which is sort of like a mental form of physical therapy, can be very helpful for this. It requires a lot of requires practice, and the idea is that if you can learn to change your thoughts and change your behaviors, then you will change your emotions. Nobody can change their emotions directly. You can't focus on making yourself a little bit happier or a little bit sadder, but you can usually make yourself happier or sadder by thinking about things, thinking about that sad time or that happy time in your life, or doing things that cheer you up, or, if you lock yourself in a small, dark room, then you'll probably start to feel sadder. So changing thoughts and behaviors is an extremely powerful technique, and psychologists have developed a whole repertoire of techniques to help people do that. and it doesn't necessarily require a lot of physical activity or a lot of or many long hours. Often people will be seen every 4 or 6 weeks, and then they'll get homework, and then they have to do the homework. So the main things that determine the success of CBT, I think, are if people are able to focus and stick with it and do the homework. Often it's very helpful. In conclusion, this is a psychiatrist talking to a client who says, "I don't know why everyone thinks I should be so happy." And I think a lot of the patients here, they see a psychiatrist, they'll see a psychiatrist and say, "Well, what, do I have a lot of reasons to be happy?" But I think the point is that, even if you're a clam, you can maybe still be happier than you are, and doctors can help you get there. Thank you for your attention. I hope you're able to hear most of that.
Thank you very much. Is Dr. Poole here? Oh, okay. Okay, next we have Dr. Jeannie Poole, who is going to talk to us on the diagnosis and management of cardiovascular symptoms in MSA. Welcome.
Thank you. I guess it's this one that's on. Hello?
And you'll need to hold the mic really close to your mouth.
Okay. All right. Let me just get this pulled up. Well, thank you for inviting me to this conference today. I've really enjoyed being here all day long. I have to say that in cardiology, the kinds of struggles that you're dealing with are not necessarily the ones that we see, but we certainly take care of patients who have problems with the autonomic nervous system, and so they do overlap with many of the symptoms and problems. Even closer? Oh, goodness.
You almost have to kiss it.
Yikes. All right. Is that better? Okay. All right. So I'm a cardiologist, and my specialty field is actually something called electrophysiology. And it's called electrophysiology because we deal with the electrical system of the heart. So the heart, of course, is a strong muscle that pumps, but we think of it as an electrical organ because the kinds of patients that we're predominantly seeing or whom we're trying to rule out a certain kind of problem in are patients with heart rhythm disorders. And so the way that we've tended to get involved in patients that have had disorders of the autonomic nervous system is because they pass out. And because passing out can sometimes herald a life-threatening rhythm disorder, patients often come to see us. And so the kind of symptoms that actually get a patient to the cardiologist or our specialty field, electrophysiology, are syncope, which you've heard that term, I think, today. So that's totally passing out. Near syncope, feeling like you're nearly about to pass out, but you manage to get yourself to ground and safety. Palpitations, so a feeling of fluttering of the heartbeat or a racing heartbeat. Lightheaded or dizzy spells, which is a very sort of non-specific symptom. But again, because it can herald a heart rhythm disorder, we'll often see patients that are complaining of recurrent lightheadedness or dizzy spells. Now, if patients have a known heart rate that's too fast, that's a tachycardia, or too slow, a bradycardia, for sure, those are the kind of patients that are going to get to an electrophysiologist. Now, our first order responsibility is to rule out what we call organic heart disease or primary arrhythmia syndrome. So something that's actually structurally wrong with the heart. Or patients who might not have anything structurally wrong with the heart. That is, they haven't had a heart attack, they don't have coronary disease, they don't have a heart valve problem, but they do truly have a heart rhythm disorder, and we call those primary electrical diseases or primary arrhythmia syndromes. But when we see patients with the list of symptoms that I mentioned in the first bullet, and there's no evidence of structural heart disease, and we don't think that they have a primary electrical disorder, then the heart rate and blood pressure response that's abnormal might be explained by a situation that is affected by the autonomic nervous system. So you've seen a lot about how the autonomic nervous system works today, and both the parasympathetic and the sympathetic limbs of the ANS affect the heart. So at rest, our hearts spontaneously create electricity, which is a really interesting phenomenon. So there are cells that are termed the sinus node. I don't know who came up with that, but that's just what it was called, up in the right atrium. And those spontaneously create electrical discharges that then propagate through the heart to cause your heart to beat. But what changes the heart rate of those spontaneously, what we call depolarizing cells, is what's going on with the sympathetic and parasympathetic nervous system. So on the sympathetic side, there's a drive to increase the heart rate, and on the parasympathetic side, that's the balance, and your heart rate normally slows down when you're at rest or when you're sleeping at night. So the brain, of course, is the origin of all of this effect and is a very important aspect of how the heart rhythm is controlled. And what we see then is the result of all of this on an electrocardiogram. You've probably all had electrocardiograms, and you know that they are those little squiggles that run across a piece of paper when you're hooked up to a bunch of electrodes. And this can be an electrocardiogram that you get in the office, or you could go home with what we call an ambulatory ECG. And that tells us how well your heart is working electrically. But that's not the whole story from the cardiologist's perspective. It's also what the autonomic nervous system is doing out in the periphery, that is in your vasculature of your legs, in your stomach, and in your arms. Because that's where sort of momentary blood pressure control is happening when you stand up, or when you're trying to exercise, or when you're trying to do any other kind of activity. This whole flight thing is, of course, very important, because what we want to have happen when we get up to exercise, or if you're in pain, or you're in a stressful situation, we would expect the blood pressure to go up and the heart rate to go up. But that doesn't always happen in disorders of the autonomic nervous system. Maybe the blood pressure is going to fall because there's inadequate control of the peripheral vasculature, or the heart rate doesn't go up as it should, or it completely drops out of the bottom. These are findings that we as cardiologists might identify in patients with autonomic nervous system disorders. So the disorders that we more commonly see are more benign, but they can really interrupt people's quality of life. And there are certain aspects of these disorders that are very similar to many of these symptoms and signs that you've been hearing about all day long with neurogenic orthostatic hypotension in the setting of MSA. So one of the most common ones is what we call neurocardiogenic syncope, and it's really vasovagal syncope, or people who faint at the sight of blood. But it's an exaggerated response. That is, these people didn't have like just one episode of fainting in their life, like many of us have had one time where we fainted or come close to fainting. You're in too hot of a room and you're standing up and your legs are locked. But these people tend to do it a lot. So it becomes a quality of life issue, and it can be a serious problem if they're harming themselves, breaking an arm, hitting their head. So what really causes this is not entirely worked out, and it may be on a multifactorial basis. That is, it may not be the same for all of these individuals. But there are common triggers. There's something called cough syncope. So people who cough really, really hard can have one of these abnormal responses to the autonomic nervous system effects on the heart, and their heart rate goes down and their blood pressure goes down. Or individuals who get up in the middle of the night to urinate can have this happen. Or in the settings of illness and stress, dehydration, the obvious things, pain, fright, or prolonged standing. The patients who have prolonged standing are the ones that often get to see us because they don't have a trigger that they can manage very well. They've gotten up, they've been doing fine for 10, 15, 20, or even 30 minutes, and then they may have a few symptoms that tell them that they're in trouble and they have to get down or they're going to pass out. So treatment is mostly conservative. So we like to make the patients be aware of their fluid status. So increase their fluid intake, increase their salt intake. It's the one time in cardiology where salt's good is for patients like this. Otherwise, salt's mostly bad for the kind of patients I take care of most of the time. We train people to be aware of the triggers. So get up slowly from a supine position. If you're likely to have this happen in the middle of the night, exercise a lot of caution. And like you've heard today, exercise is very important. So the more deconditioned people become because they're afraid of passing out, the worse the problem is going to get. And rarely are medications needed, although sometimes we do prescribe medications, including the SSRIs that you just heard about. Now, another syndrome that can affect quality of life significantly is something called postural orthostatic tachycardia syndrome. And these individuals have inappropriately fast heart rates when they stand up. So it's usually defined as equal to or greater than 30 beats per minute within 10 minutes of standing. And while their blood pressures rarely fall, they feel terrible standing up. Generally affects younger women and is pretty prevalent. About 0.2% of the young female population experience this. But even beyond that, these patients complain of just general brain fog, and they can have GI symptoms, migraines, These people frequently have migraine headaches, and it can be triggered by viral stress or other stresses. And again, the treatment is mostly conservative. Paying attention to your fluid and your salt intake, being aware of triggers, continuing to exercise, not shying away from exercise. And again, rarely medications are needed, but sometimes we'll use propranolol. You just heard about propranolol. It's a beta blocker. It can slow the heart rate down. Or a new drug called ivabradine, which is not FDA approved for this indication. It is approved to bring down the heart rate of patients with heart failure, but it can be helpful. And the third sort of benign entity that we often see is something called inappropriate sinus tachycardia, where the heart rate is just always too high. So that feels very uncomfortable to people. Again, it's mostly seen in young people, but can cause significant quality of life issues and psychosocial stress. We try to avoid exacerbating triggers, that is, get them to stop drinking alcohol or caffeine, make sure that it's not another medication that's causing it, or consider ivabradine, this medication I just mentioned, that is for off-label use in this situation, but has really, really dramatically changed our ability to treat these patients. So we use some tools and tricks of our trade to figure all of this out. We like ambulatory ECG monitoring. Sometimes that goes by the word Holter monitoring, so you can get hooked up with a bunch of electrodes and go home and wear this monitor for 24, 48 hours. And now there's actually long-term monitors that you can actually wear out to a month. And there's a lot of information we get from this. First of all, remember, as a cardiologist, we're trying to rule out real arrhythmias. So that's one of the main reasons we're doing this. But we can also look at heart rate trends. So this is an example of somebody with 24-hour heart rate plot. And what you can see is that's in black, which is the heart rate, is always over 100 beats per minute and can go up higher than that, 120, 130, 140 beats per minute. That is just simply abnormal. And these patients, if left over time, potentially can even develop heart failure long term. So it's important to try to approach these patients very thoughtfully. And that's very different from the rest of us who don't have disturbances of our autonomic nervous system, where most of the time our heart rates are pretty normal, between 50 and 80 beats per minute, and intermittently our heart rates will go up in the correct situations, such as exercise or when we expect it to go up, say with a fever. So Holter monitoring can give us a lot of clues about what the heart rate is doing over time. So as I said, we're looking for real arrhythmia. So here is a patient who didn't feel well when they were upright and just started to do mild exercise. This was in an older individual. And why was that? Well, this monitor told us that this patient was actually having a true arrhythmia. You can see on a heart rate plot, which is on the left, that sudden spike up in the heart rate. And it goes really high, up to 220 beats per minute. And that rhythm is very chaotic and irregular, and that's what it would feel like if you can feel it. And this is atrial fibrillation. It's a very common rhythm abnormality, especially as we all age. But a lot of people actually don't feel this, which is amazing to me. I don't know how you cannot feel something going 220 beats per minute. But sometimes all people know is that they don't feel well or they feel lightheaded when they're upright. So it's important to rule out true arrhythmias. Now, another way that we can monitor patients to better understand what's going on with their heart rhythm is something called an implantable loop recorder. And this is a very little monitor that we actually just insert underneath the skin. So it's about 1.5 inches long and about 1/4 of an inch wide. And you can make a little nick in the skin and just slip it right under the skin, and it can stay there up to 3 years. And what's nice about these monitors is they'll automatically trigger for a very serious too high heart rate or a very serious too low heart rate. And as well, we can intermittently interrogate it by making a link with a programming head, is what we call it. It makes a radio frequency link, and we can print out what's happening with the patient. So this 28-year-old male had had a couple episodes of passing out. Wasn't entirely clear what was going on with this patient. And with this implantable loop recorder, he called us up and said, hey, I was sick, my kid was sick, I got up in the middle of the night to go pee, and I passed out and hit the toilet. Okay? So it's sounding very classic for one of these vasovagal type events, and lo and behold, we saw the patient's heart rate. Now, we didn't have the patient's blood pressure, but we knew that the patient was otherwise normal, and we can see that the heart rate slowed down and then came right back. Some of these patients who have vasovagal syncope have profound slowing of the heart rate. But because the underlying heart is actually normal, the heart rate always picks up and it always comes back, even though it can look pretty scary. So another trick that we've used through the years to try to help understand what's going on with individual patients is tilt table testing. And so with a tilt table, the patient lies down very calmly. You measure the blood pressure and the heart rate. You raise them up to 60 or 70 degrees and strap them in, and you just leave them there. It can unmask some of these autonomic nervous system problems. Can also help tell you if what you're dealing with is actually true orthostatic hypotension, such as seen in MSA. So here are some examples of different responses on a tilt table study. And on the left, all of the little squiggles going along for the first 8 to 12 lines, they're simply the heart rate. This is a piece of paper running at fast speed, so it looks like the heart rate's going really fast. It's probably going about 100 beats per minute. And where it says BP there, that's the patient's blood pressure. You can see that the patient was lifted to upright tilt. The blood pressure initially goes up a little bit and then just plummets. It goes down to about 40 or 50. The patient passes out. We lay the patient back down and their blood pressure comes back up, but there was not really much change in heart rate. So that's one kind of effect you can see. And in patients who have vasovagal syncope, they usually don't pass out for about 10 to 20 minutes after standing upright. And on the right-hand side is another example of a tilt table where the patient also had EEG monitoring going on simultaneously, so you can see what's going on in the brain. And this patient not only drops their blood pressure, which is that kind of sagging line about third or second to the bottom, but also has a period of no heart rate. That's where it says asystole. Some of these patients can have 20 or 30 seconds of no heartbeat. And again, it seems pretty scary, but if they don't otherwise have something wrong with their heart, the heartbeat always comes back. And very, very rarely do we ever have to insert something like a pacemaker to protect that patient. That's very unusual. Here's an example of a patient who simply has an inappropriate rise in their heart rate. That's called, again, POTS, or postural orthostatic tachycardia syndrome, where upon standing up, their heart rate simply goes too fast, but they don't actually drop their blood pressure. Now, this is what orthostatic hypotension looks like, such as in MSA. So the difference is that very quickly upon standing upright, within 1 to 3 minutes, the blood pressure drops. And that's how we can distinguish it as being something different than the other more benign entities that I told you about. So this is what orthostatic hypotension would look like in a tilt table for anybody in the room here who has this problem. It can also be seen in pure autonomic failure or some of the other disorders that directly cause orthostatic hypotension. So it's a very distinct pattern that's different on tilt table testing. So the causes of neurogenic orthostatic hypotension, there's actually quite a number of them. Of course, there's pure autonomic failure. You've heard that mentioned today. The orthostatic hypotension that's associated with Parkinson's, and of course, multiple system atrophy. There are other disease processes, though, that can also secondarily cause orthostatic hypotension, and these are some of the ones that, again, we might more often see in cardiology. So patients with something called sarcoidosis, that's an inflammatory disorder that affects the heart, affects the lungs. It can definitely affect the autonomic nervous system, and people can have a terrible time with feeling poorly with their blood pressure dropping in the upright position. Another disorder that can cause autonomic nervous system orthostatic hypotension is something called amyloidosis, and that's where the body makes too much of a certain protein, and that protein gets deposited into the heart, into the lungs, into the kidneys, and can affect the autonomic nervous system. Probably one of the most common causes of orthostatic hypotension are patients who have diabetes. So these are other entities that we in cardiology would be looking for. And simply getting old. There's a prevalence of about 5 to 30% of the normal aging population that has problems maintaining their blood pressure in the upright position. Now, we also would be looking carefully to make sure that we haven't caused orthostatic hypotension, and this is important even if you have neurogenic orthostatic hypotension from MSA or any of these other entities. We want to make sure that we're not making it worse. So if patients are on drugs specifically to treat blood pressure that's too high, that might be making it worse. Or if they're on medications to help people whose prostates are enlarged, that can make orthostatic hypotension worse. Some of the anti-Parkinsonian medications, as you heard, can make it worse. Tricyclic antidepressants can sometimes make it worse. And for sure, if the patient's dehydrated, they've had GI bleeding, or any other reason that their blood volume is down, that's going to make it worse. One of the big problems with neurogenic orthostatic hypotension as well as secondary orthostatic hypotension is that when patients lay down, their blood pressures are too high. That they can be so high that you really have to treat this. And this can be a problem in managing the medications as if they're working against each other to keep the blood pressure up when somebody's standing upright, but have it not be too high when they're lying down at night. And that can be one of the real challenges. So the symptoms can be certainly anything from passing out to feeling like you're going to nearly pass out, but sometimes they're less severe, but simply can be dizziness, visual disturbances, feeling tired, impaired cognitive performance, feeling overall weak or fatigued, feeling like your legs are going to buckle, visual blurring, or being short of breath when you're upright. All of those potentially can reflect the orthostatic hypotension or the blood pressure that is inadequate. You've heard about head, neck, that somebody's not having angina, chest pain, due to coronary artery disease, such as you get with having a myocardial infarction or a heart attack. The symptoms can often be aggravated in hot weather, fever after heavy meals, or after prolonged standing, and particularly in the early morning hours. Morning symptoms can also be due to the fact that when you lay down at night, you can diurese, that is, your body is trying to get rid of fluids by the fact that your blood pressure is too high when you're laying down. And so managing that is one of the prongs of therapy if a cardiologist is also trying to help manage a patient who has high blood pressure when they lay down at night. From our perspective, if we refer a patient to make sure that we're either working together with the other physicians or to make sure that you don't have a primary cardiac problem, always starts with a good old history and physical. So we're going to be looking for any other reasons that might be exacerbating the blood pressure problems. We're going to be making sure that the history doesn't suggest a true abnormal rhythm, that is, do the symptoms come on suddenly, especially if you're sitting or already lying? That's going to make us start thinking, I wonder if that person actually has a heart rate that suddenly goes too fast, like the example I showed you. We're going to be looking for and trying to rule out other primary heart troubles caused by high cholesterol levels, diabetes. Do you have a smoking history? Of course, the hypertension issue is very important, or a family history of early coronary disease. All of those sorts of symptoms are going to send us down a pathway of making sure that we're not missing coexistent heart disease. And kidney disease is also very important because that's clearly involved in regulation of salt and water in the body. What about the physical exam? Well, we're going to be listening very carefully to the lungs, make sure there's not fluid in the lungs, making sure we're listening to the heart, that you don't have a heart murmur, to suggest something like maybe your aortic valve, one of the main valves inside the heart, isn't too narrow. That's a cause of why people can drop their blood pressure when standing up and pass out. And that's a very serious problem that needs evaluation. And of course, we want to document that you actually have orthostatic hypotension. So we lay the patient down and we stand them up and measure the blood pressure and heart rate at 1 minute and again at 3 minutes. If there's no evidence of a primary heart problem, then we consider neurogenic orthostatic hypotension. So evaluation also would include looking at routine blood chemistries. We want to make sure that the patient's not anemic as a cause for fatigue and feeling lightheaded. Make sure the white blood cell count is normal as well as the red blood cell count, that all of the electrolytes are completely normal, the kidney function, the potassium level. We would certainly do an electrocardiogram on all patients because even though it's a simple screening tool, you can get a lot of information off of a routine electrocardiogram that again points you to the fact that maybe the patient has underlying heart problems that also need to be addressed. We would consider ambulatory monitoring, like the examples I showed you, to get a sense for the overall heart rate. Is it too high? Is it too slow? Does the patient have sudden increases in their heart rate? Ambulatory blood pressure monitoring can also be very helpful, especially to look at the blood pressures when supine and at night. There are some patients where we might want to take the evaluation further. We might want to get what's called an echocardiogram. It's an ultrasound of the heart. So if we have any suspicion at all that there's a problem with the heart in terms of its overall function, that's a very sensitive test. It tells us how well the heart squeezes, and it helps us look at valve problems inside the heart. We might even want to do a stress test if we're concerned about coronary disease. We certainly don't want to miss coronary disease in patients because that's something that we can do something about. So here's an example. Here's an older gentleman who had orthostatic lightheaded spells. Patient gets an electrocardiogram and it's read by the computer. They're all overread by doctors in the hospitals, but the computers are pretty accurate. And it reads something called, quote, a left bundle branch block. Well, what does that mean? That simply means that it's measuring how fat each of the signals are on the electrocardiogram. But it's a clue that there's an electrical problem in the patient's heart. Now, that may have nothing to do with the patient's orthostatic hypotension, but it certainly does tell us that the patient does now have an entirely normal heart. And so we would want to take that evaluation a couple steps further then. So what are some of the ways to manage neurogenic orthostatic hypotension from the cardiologist's perspective? So I think there's some simple things that can be done, like learning to get up slowly from supine to upright, to pay attention to volume and salt loading as long as you don't have a contraindication to that. You don't have heart failure, you don't have hypertension, you don't have coronary disease. Thigh-high support hose or abdominal binders. Turns out when you stand up, a lot of your blood actually goes into your splanchnic system, which is the vascular system in the gut. So sometimes abdominal binders actually work better than thigh-high support hose even do. Sleeping with the head up at nighttime improves cerebral blood flow. Eating multiple small meals rather than one large meal or even 2 large meals a day can really be helpful. Trying to minimize the carbohydrate load. And exercise at any level that you're able to do is also important and very helpful. What about medications? Well, there's some FDA-approved medications. One of them that's not FDA-approved for MSA is fluorohydrocortisone, which is Florinef. We do use that for a lot of patients with various autonomic nervous system disorders. It can be very helpful to increase plasma volume, helps the kidney hang on to more sodium. There are some side effects. There's always side effects to all medications that you have to consider. Midodrine and droxidopa are 2 FDA-approved medications that can be very helpful. Midodrine is a drug that predominantly works by improving vasoconstriction in the peripheral vasculature to help keep the blood pressure up. And droxidopa is the most recently indicated FDA-approved drug for MSA. And the drug does carry a black box warning for this problem of hypertension when patients are laying down, so you have to be monitoring the blood pressure at night as well as during the daytime for patients taking droxidopa. The mechanism is thought to be due to arterial and venous vasoconstriction with improvement in norepinephrine levels, and it has been demonstrated to be benefit to patients with MSA. There are some side effects to taking droxidopa, but overall have been reported in a small percentage of the patients. These are 2 bar graphs that look at the most common side effects that have been reported with this medication in 3 of the drugs that the FDA used and looked at to approve this study. So patients can have headaches, they might have dizziness, they might have nausea, and again, they may develop supine hypertension. So some of the challenges in the management of cardiovascular symptoms in neurogenic orthostatic hypotension. The supine hypertension, again, is probably the biggest problem for a cardiologist who's going to co-manage a patient. Sometimes patients can have an inadequate heart rate response. We call that chronotropic incompetence. Rarely, again, would a patient require a pacemaker to support that because it's not the dominant problem. The dominant problem is the blood pressure. And so a pacemaker is not going to fix that at all. But there have been occasional patients in whom we have implanted pacemakers if the heart rate really falls, and we believe that by simply elevating it, it can actually overall help the supine hypotension, but that would be a really rare instance. We would be, again, watching out for exacerbation of what we call ischemia, which is angina related to obstructive coronary disease, or worsening of heart failure if the patient already has heart failure. All of those patients certainly need careful follow-up with their cardiologists. And it's always good to keep in mind that there are different responses to medications in different patients, even with the same diagnosis. And so you have to pay attention to how the patient's responding to any treatment, whether it's medication or conservative approach. Not everybody's going to respond the same way. So who ought to be seen by a cardiologist who has neurogenic orthostatic hypotension? Well, certainly anybody that has a known problem with their heart. I think that makes sense. I think any problem that is seen on an electrocardiogram. So anything that's read as abnormal on the electrocardiogram, that patient probably ought to at least see a cardiologist once to make certain that they're not concerned that they have coexistent cardiac disease. Patients with severe supine hypertension, where you really have to work hard to figure out how you're going to manage this. I think that's a patient that ought to be co-managed with a cardiologist. And certainly if there are significant symptoms that seem to go beyond what the normal symptoms are that might present with just neurogenic orthostatic hypotension. So if chest pain seems out of proportion to some of the other kinds of pain, patients are having significant shortness of breath, significant dyspnea on exertion, palpitations, or syncope with no warning signs at all, it might be reasonable to have a cardiologist see that patient and just be absolutely certain that we're not missing some other problem that we can also treat along with treating the MSA symptoms that you're experiencing. So I'm going to leave you with that concluding remark, and thank you very much for your attention. Be happy to entertain any questions that you might have during the panel discussion.
Thank you very much. We have one last speaker. All the speakers you've heard today have been affiliated with the University of Seattle, Washington, and Bar Harbor, is it? Did I remember reading that on somebody's Harbor View? Okay, it wasn't on anybody's recent things, but I thought I remember reading that. So we thank you all very much, for coming to help us out. And next, and to close out our formal presentations, we have Dr. Maslia, and he is with us from the University of California at San Diego, and had the pleasure of, he hosted one of these conferences several years ago. And so when he was familiar with the coalition, and he actually put in a request for a grant to do some research through the 2 grants. And he's here because we gave him some money to do some research, and he's here to give us an update and also to maybe fill us in on some of the other recent things. So, and then after Dr. Maslia gives his research update, we'll open up the whole panel for more questions. So if you have them at your tables, raise them up and we'll be by for them. Thank you.
All right. Great. Thank you very much. How are we doing? We're good? All right. So I'll try to be brief. I know it's getting a little bit late and you guys still have a few more issues. What is really important, which is you, the patients, and the caregivers, to mice. So I'm going to go from human to mice, okay? But just bear with me. So we were very, very lucky, and we're very thankful to the MSA Coalition, to Judy, to Pam, and to many others for the support for the research that we perform in the lab. I've been working on MSA for the past almost 20 years. Initially, most of the work that we were doing was looking at the brains and try to identify what was the cause or the substrate for MSA. And now we have done considerable progress in developing animal models of MSA where we can test new drugs. So as I said, we were extremely lucky that we received this support from you guys, and we're very thankful. So the study that we were funded about a year or so ago, which is this one that I'm showing here, we just recently published it. It came out just about a week or two ago in the journal Molecular Neurodegeneration. And essentially, the purpose of this project was try to use a natural protein in the brain, an enzyme, that actually what it does, as you can see here illustrated, it cuts alpha-synuclein. So we're going to talk a little bit about alpha-synuclein. So alpha-synuclein is this protein that is in our brains and in other regions, but primarily in our brains, and it's very important in the communication of cells with neurons. But in MSA and other disorders like Parkinson's disease, synuclein clumps and becomes toxic. So this enzyme that we all have in our brains that we call neurosin actually works, let's say, like a natural scissor. and it causes neurosine in such a way that that alpha-synuclein won't clump in the brain. So what we did is that we developed a totally new strategy to reconstitute neurosine and give it peripherally, and then show that it can get into the brain and that it can reduce in our animal model of MSA some of the bad things happening in the brain. So that's what this paper is all about. That's what we were funded for, and I'm going to show you a little bit of data. So before that, let me just give you a little bit of background. I know that many of you are very knowledgeable about this. You have read a lot, or probably you have heard from your doctors. But the protein that I'm very interested on is this protein named alpha-synuclein. We discovered alpha-synuclein in the early 1990s in the brains of patients with Alzheimer's disease. We thought that this protein was involved in the pathogenesis of Alzheimer's disease. However, long and behold, genetic work that was done at NIH and by other groups discovered that mutations in this protein actually cause Parkinson's disease. But later on, we developed markers to find synuclein in the brain, and we actually were able to see that synuclein also accumulates in the brains of patients with Alzheimer's, as we originally predicted, as it was also predicted by others in the brains of patients with Parkinson's disease. But then a student of mine that now is in Japan discovered that alpha-synuclein can also accumulate in patients with MSA. And what he discovered is that alpha-synuclein, unless, as is the case in Alzheimer's and Parkinson, where synuclein is accumulating in the neurons and form these round globular structures that we call Lewy bodies, in MSA, it accumulates in a completely different cell that is not a neuronal cell. It's what we call a glial cell, which is a support cell of the brain, and these structures are called glial cytoplasmic inclusions. As I mentioned before, we also discovered at that time that alpha-synuclein is a highly abundant protein in the neuronal connections, in what we call the synapses. So almost every single synapse contains alpha-synuclein. And under normal circumstances, this alpha-synuclein in the neurons, that is in the synapses, is very important for the communications within cells. You heard from the other speakers about neurotransmitters, about cell-to-cell communication. Well, alpha-synuclein under normal conditions help neuronal cells talk to each other. Now, what happens in MSA? Well, we don't really know, as I pointed out here, but something happens to that alpha-synuclein that changes from, let's say, a conformation or a structure, let's say, that is round like this, to a conformation that is like a square. So we call that misfolding or changing conformation. And that new conformation leads to the aggregation of the alpha-synuclein, the clumping of alpha-synuclein, and the formation of these sort of like donut-shaped aggregates of synuclein, and then later all these fibrillar shapes of alpha-synuclein, which we actually find in the glial cytoplasmic inclusions of MSA, in these cells called oligodendroglial cells, and in neurons, which is the case of what we see in disorders with Parkinson's disease. Now, in the nervous system, as you all know, we have, again, these cells, which are the neurons that communicate one with the other, and the great majority of the functions that we display are due to that communication. And the oligodendroglial cells actually wrap the communication, the cables of the neurons, and these are sort of like lipidic fat wraps that help those electric impulses carry on better. So again, while in Parkinson's disease, the alpha-synuclein clumps in the neurons, clumps here, in MSA, it turns out to clump in a different type of cell that are called the oligodendrocytes. And again, this is how it looks in the brain. And these oligodendrocytes actually are in the part of the brain that we call the white matter. So a lot of the pathology that we see in the brains is in the white matter, causing a lot of the peripheral and central effects that are manifestation of MSA. So what we did in the lab several years ago was to actually genetically engineer a mouse where alpha-synuclein will accumulate utilizing a specific trick, a specific genetic trick, will accumulate in the oligodendroglial cells of the mouse. And these mouse actually develop several of the cardinal features that we see in patients with MSA. Now, what is a mystery, and we still don't understand what's happening either here, is why alpha-synuclein, a protein that is normally in neurons, ends up in the oligodendroglial cells in patients with MSA. How is this happening? How is this translocation or transferring of synuclein from neurons to glial cells happening? So there is a very recent paper that probably many of you have heard about that was just published also a week or two ago by the laboratory of Dr. Stanley Prusiner. He's a Nobel Prize winner. He discovered prions, which are the cause of another neurodegenerative disorder called Creutzfeldt-Jakob disease. And Creutzfeldt-Jakob disease is a very rare transmissible neurodegenerative disorder caused by this protein called prion, which again misfold and let's say damage other neurons very rapidly. So what the lab of Dr. Prusiner did is that he took brains from patients with Parkinson's disease and with MSA. They extracted that alpha-synuclein that I just told you about. In fact, they extracted this fibrillar form of the alpha-synuclein from the brains. And what they did is that they injected it into the brains of another alpha-synuclein transgenic mice. And what they found is that when they inject brains of MSA patients, or these alpha-synuclein fibers for MSA patients, the pathology of MSA develops very rapidly in those animals. Now, I mean, they interpreted this to call it that MSA is a prion disease. Not everybody is completely in agreement with this. We're not particularly in agreement with this, but I think what it means really is that alpha-synuclein is getting out of the neurons, and it's getting into the oligodendroglial cells. And if you put more alpha-synuclein, let's say from an MSA brain, it's going to seed, it's going to absorb, it's going to take that material, and then you're going to see more accumulation of that protein in the brain. But I think it's a very important observation, because I think this gives, again, a lot of visibility to MSA in the general neurological disorders field, especially coming from a lab, from somebody that won a Nobel Prize. So now, knowing that and having that information, how can we develop new therapeutics for MSA? I think many of the therapeutics that we have heard today, controlling urinary problems, hypertension, etc., are extremely important, and I think we should continue to work on those so-called symptoms of the disease. But really, to find a cure for the disease, we're going to have to go after the culprit. And the culprit, as I mentioned at the beginning, is the clumping, the accumulation of alpha-synuclein in the oligodendroglial cells, in the cells that make the myelin in the brain. So how can we target this? How can we reduce the alpha-synuclein in the brain? So there are a number of strategies, and I'm really not going to go over all of them, but just suffice to say that you could decrease the synthesis of synuclein in the brain. You can decrease the clumping of synuclein in the brain. You can give some drugs that are anti-clumping, let's say. And you can also increase the clearance of synuclein in the brain. So like everything else that is formed in the body, it accumulates, and then there is like a garbage disposal system. So when I say clearance, I basically mean increase the garbage disposal. It's like something is clumping in your sink. Well, you turn the garbage disposal. If that machine doesn't work, stuff is going to accumulate, and it's not going to be very good. So what we wanted to do, and I'm going to talk to you about two strategies. One is the neurosine strategy that we just recently published, and another one utilizing antibodies. So, as I mentioned before, so neurosine is this enzyme that helps the garbage disposal system of the brain by cutting, by cutting alpha-synuclein at two very specific sites where are very sensitive. So this area here in yellow, it's an area which is very, very sticky. It's really almost like a molecular glue. We call this area, we denominate this the NAC region of alpha-synuclein, and it's like super sticky. So neurosine actually cut alpha-synuclein at the sticky point, and it helps the nervous system to clear the excess alpha-synuclein. Now, we have measured the levels of alpha-synuclein in the brains of patients with Alzheimer's disease, with Parkinson's disease, and also MSA. I'm not showing the MSA data here, but we have also measured in MSA, and in all the cases, the levels are significantly reduced. We see the same thing in our animal models of Parkinson's disease and MSA. The levels of these enzyme that cuts synuclein are significant, but of course, again, you inactivate the bad parts of the virus, and then you can put that in a cell, and you're going to get the gene that you're interested in inside a cell. So that's exactly what we did. We constructed this virus with the neurosine protein, and then we injected this virus with the neurosine gene in the brain of our alpha-synuclein transgenic mice. And we show, and here is in brown, this is alpha-synuclein accumulating in the brains of our animals. And what you see here in blue is the neurosine that it's been expressed in the brains of these animals using this Trojan horse strategy. And as you can see, when we express high levels of neurosine, the levels of alpha-synuclein are significantly reduced, and these animals are protected. So we published this paper a couple of years ago, and then speaking with Bob Yant and with a number of other members of the MSA coalition, we thought, well, why don't we try this on MSA? Now, here is a problem. There was a significant problem. In the case of Parkinson's disease, since the synuclein that accumulates in the brain in Parkinson's disease, as you all know, tends to be limited to a very specific part of the brain, if you inject it directly in the brain, well, you have a good chance to hit the bad stuff. The problem in MSA is that the alpha-synuclein accumulating in the brain is in many different parts of the brain. It's diffusely distributed in the brain. So what we needed to do is to get the neurosine into the brain from the periphery in such a way that it would distribute it throughout the whole brain. But so how do we do this? Trojan horse to get into a cell in the periphery, for example, in the liver, and have the liver cells making the neurosine. But now we need another Trojan horse to get into the brain, and for that neurosine only to get into the brain. So I have a really smart guy in my lab that discovered that if you put this motif of a lipid binding protein into the neurosine, actually it will work as a Trojan horse for the brain. So it's almost like, the brain has a barrier, and it's illustrated here. This is called the blood-brain barrier. So the brain has a protection mechanism, an evolutionary protection mechanism to prevent bad things from getting into the brain. But at the same time, it prevents good stuff that you want to get in there to get in there. So you need a key. You need a special mechanism to get in there. So that's what this little mark in red is, this ApoB, which, as I said, is a lipid binding protein which happens to have that secret code, secret key to get things into the brain. So when we injected our animals, we injected them peripherally with the virus, with the neurosine and the ApoB. The liver took that virus. The liver cells make the neurosin with the ApoB. The neurosin ApoB circulates into the blood, and then that ApoB key binds to the cells in the brain and gets inside the brain. And this here is a demonstration of that. Essentially, brown, dark brown means that there is a lot of the protein in the brain, and light brown means that there is not much. And essentially, when we use our neurosin ApoB, we can see that a lot of that protein is getting into the brain, and it's getting throughout the brain in those areas that are affected by MSA. Now, we did another trick. I didn't tell you the other trick, but this is another cool thing. My folks in the lab had this idea of mutate the neurosin in order to make it more active. Because what it turns out is that we discover that the that the alpha-synuclein that accumulates in the brains of patients with MSA is so sticky and so difficult to remove that you actually have to give it a second pull to that enzyme and make it even stronger. So you can achieve that by mutating neurosin, and that's what we did. So we had to do three little tricks to make this work. But we were able to find the neurosin in the brain, and essentially this is to remind you what we were talking about. So these are the neurons. These are the oligodendroglial cells that are wrapping the neurons and are making things easier to conduct. And what we did is that we measured where this neurosin is going in the brain from the periphery, and we find that it actually was going into the neurons, was going also into these glial cells, which again help clean, they are part of that cleaning system in the brain. And when we measure the alpha-synuclein, so this is a control, and this is with neurosin. So each of these dots here represent a GCI or a oligodendroglial cell. Again, this is the oligodendroglial cell in blue, accumulating alpha-synuclein. So when we have high levels of neurosin in the brains of these animals, we see a significant reduction on the levels of alpha-synuclein. And when we measure the number of neurons and we measure the levels of inflammation, we see a reduction on inflammation and a normalization of the number of neurons in the brains of these synuclein transgenic animals. Now, the other thing that is really important, as I mentioned to you before, that the oligodendroglial cell is doing in the brain is wrapping the wires in the brain such that conduction would be better. And in MSA and in our synuclein transgenic mice, this myelin, which here is in blue, is significantly reduced. And it's all messed up, and it has several problems. So in the presence of neurosin in the brain, we see a significantly normalized myelin. Now, all of that is very nice and is interesting pathological data, but what about functionally? So we also are able to test our animals, and they do display motoric and activity deficits. And in the presence of neurosin, the activity of these animals is very similar to what we see in the control animals. So what we think is happening here is that then the neurosin that we're giving peripherally with our special Trojan horse and mutation trick, it's getting into the brain. It's taken by oligodendroglial cells, by neurons, by astrocytes, and then these cells are degrading or digesting the excessive sticky alpha-synuclein, and then that it's passed into another type of cell that is sort of like the garbage disposal cell in the brain that is called the microglia, and that pretty much is the project, and that is the story. Now, just very briefly, I want to tell you a couple of things. Of course, the objective would be to develop this technology into some sort of a clinical trial for something that could be tested in patients in the future, and that's precisely what we're working on. To achieve that, we would have to, at first, not use viruses. So obviously we don't want to be putting viruses in people, even if these viruses are safe, relatively safe and inactivated. So what we would need to do is to actually make the protein, and then we would need to make it at high levels, and then first test the safety of these proteins. So that's what we're currently doing. And again, we need to, of course, obtain a considerable amount of funding to do that, but that's what we're working on. Now, at the same time, we're working on another strategy, and this strategy involves antibodies. So antibodies work a little bit different than neurosin, but also work. Antibodies, what they do is that they specifically recognize the protein of interest, in this case, the alpha-synuclein, and they can also help the garbage disposal system of the body of getting rid of the synuclein aggregates. Now, there are two different types of immunization. There is something that we call passive and active immunization. In the active immunization, you take the actual synuclein and you let the body make the antibodies. And in the passive immunization, you actually make the antibody outside of the body, and then you inject the antibody to the person. So, for example, many of the antibodies that are out there, for example, for cancer or for arthritis, are antibodies that are made synthetically in the lab, and then they are injected to the patient. So that's passive. And we have developed both, and I'm really not going to go in detail over this, but I just want to give you an update. We have developed both with a company in Austria named Apheris an active immunization therapy for Parkinson's disease and MSA, utilizing these small peptides that this company generated, and we inject the peptide and the body generates the antibody. And we have demonstrated both in our Parkinson transgenic mice, this is from the Parkinson mice, as well as in our MSA transgenic mouse model, that we can reduce the accumulation. Again, these are the aggregates of synuclein in the brains of the mice, and we can reduce the accumulation of synuclein in the brains of our model, both of Parkinson and MSA, with this particular strategy. We also have developed with another company called Prothena Pharmaceuticals antibodies, synthetic antibodies that we can inject from the outside. And those antibodies also work in our animal models of Parkinson's disease. And the exciting thing, I think for me, hopefully as well for you guys, is that both of these strategies, the active immunization and the passive immunization strategies, have now made it to clinical trials, to what we call phase 1 clinical trial. And what that means is that we're just trying to see if these new drugs are safe. So there is a clinical trial for Parkinson's disease with the Apheris and Michael J. Fox active immunization, and now there is another one ongoing on MSA patients, and this is happening in France and in some other parts in Europe. And then we have this passive immunization with antibodies with Prothena and Roche. We have tested these antibodies in normal individuals as well as in patients with Parkinson's, and we know that these antibodies at least are safe. So the next step will be to test both of these strategies in patients both with Parkinson's disease and MSA, and look for pharmacological response. Now I'm almost done. This is my last slide. And so what is next for us? So number one, as I said, we're trying to figure out a way to develop the neurosin strategy into a phase 1 clinical trial, and we're working really hard on that. But also, we continue to work on this vaccination approach. And we recently got another grant from the MSA Coalition, and again, we're very, very thankful for that. We really appreciate your support. But what we have is a relatively new idea. We think that just one strategy, let's say an antibody or neurosin or one approach is not going to be enough, that we're going to have to start trying combinations of things. So another big problem that we see in the brain in MSA and in Parkinson's disease is, in addition of the accumulation of the synuclein, there is inflammation in the brain. And part of the reason for that inflammation is because the synuclein also accumulates in the inflammatory cells in the brain. So for this experiment that we're going to be conducting, we're actually going to combine the antibody strategy with the anti-inflammatory drug that is currently in the market, and it is actually utilized for some inflammatory disease, but also is utilized for a type of cancer of the blood that is called multiple myeloma, and this drug is called lenalidomide. So we're going to be doing this double hit treatment, immunotherapy, and anti-inflammatory agents, and we'll see how this goes. I think the interesting thing about this is that some of these drugs are already in the clinic and are available. So the other thing that we try to do is see if anything that is already currently available might be useful. This is what we call repositioning. So that's what we're going to be working. So I just want to close by acknowledging the people in the lab that did the work, our collaborators in academia and industry, and again the MSA Coalition and NIH and others for their help and support and funding. Thank you.
Thank you very much. Don't go too far away, Dr. Vanzia. If you all would join Eliezer up on the podium for the Q&A. If anybody has questions, raise them up. We have, 10 or so already up here that have come in. And then don't everybody rush out right afterwards. We've got a couple of announcements when the Q&A's over. We just really appreciate all of the speakers today and yesterday. Dr. Cholinsky had a medical offering for some medical staff that included patients, and that was very well presented also. So, okay, it looks like, give them a couple minutes because the handwriting on some of these was not really readable. So that was one of those was mine that wasn't readable, by the way. So.
here. So, do you want to start?
Okay, so we're ready to start the questions. If you cannot hear us, just raise the hand or wave because it's difficult with this mic. So one of the questions that I had was, why is it the morning light that you need to raise your serotonin? Will outside going through during any other time of the day help? So early morning light has a special short frequency light that is about 560 nanometers. Not that you want to know it, but it's early morning short light, and it's not present during the other parts of the day. So it's early morning light. Now people ask me, well, do you have it in Seattle? Yes, you have it in Seattle. You don't have to move to Hawaii. Now, is there more light in Hawaii? Perhaps. And the darker the eyes you have, the more you're protected against living in you're designed to live in warm climates, I should rephrase that. So you might need to go for a longer period of time compared to the people who have light-colored eyes. Okay, so it's not fair, but that's what it is. So people ask me also, do they need to go naked? No, it goes through the eye. So and the other part was, does sunscreen decrease it? No, because you don't put the sunscreen in your eyes. So it goes purely through your eyes. So sunglasses was another question. Can decrease it probably. Regular glasses are probably too thin. There was a physicist at the University of Washington who has been researching it actually on mice. And he assured me that I don't know how he was doing the sunglasses, but regular glasses probably okay, sunglasses not so much, and it does not cross the windows. So you have to open the window or go outside. So I'm going to...
All right. Some of these questions I think are more general questions that maybe held over from this morning. We'll try to answer them as best we can. So one of them is, or a number of them are questions about the diagnosis of multiple system atrophy of both types. But this particular one is a question about testing or findings that would help differentiate pure autonomic failure from multiple system atrophy. And as I think a number of us have alluded to today, the diagnosis of multiple system atrophy can be tricky because there are a number of other diseases that have very similar patterns of symptoms, at least early on, and it can be difficult for neurologists to be able to distinguish between them, and in fact there may not be any good way at this point to do that. One of the things about pure autonomic failure, it can look very much like multiple system atrophy at the very beginning when there's mostly autonomic symptoms. It turns out that in pure autonomic failure, a different part of the nervous system is affected earlier. It's more of the peripheral nerve part rather than the central part of the autonomic system. And so there is testing available, really testing that focuses on the production of sweat, and that can be done in a couple of different ways that can tell us whether the peripheral part of the system is affected or the central part. And it isn't perfect, it's not the only criteria, but that's one test at least that can be used to help differentiate at least the location of the problem. And if we really felt strongly that it was a peripheral nerve problem, that would be more consistent with pure autonomic failure than with multiple system atrophy. It turns out that later in the course of multiple system atrophy, that's not necessarily the case, that you can also have some evidence of peripheral nerve problem, but early on it can be helpful.
So I had two questions related to Provigil, also known as modafinil. What do you suggest if your doctor doesn't want to prescribe Provigil and you have fatigue? That is a common situation. I kind of alluded to that people Provigil is a controlled substance. It's not controlled the way things like painkillers or amphetamines are controlled, but it is a controlled substance. It has some abuse potential, and a lot of doctors haven't worked with it. Some insurances won't cover it. What I'd honestly suggest is try to work with your doctor, and at some point, if they're not really comfortable with it, see if they can refer you to someone who does have more experience with treating fatigue and those types of symptoms. I tried. It is generally considered very safe, and I think usually trying to engage in a dialogue with your provider is the best thing, rather than sort of trying to override them, find out what their concerns are. And a lot of times, at least in my experience, doctors are not opposed per se to prescribing these things, but they're like, I'm not that kind of doctor. I don't prescribe that kind of medicine, and I'm really uncomfortable prescribing something that I've never done before with someone who's already got medical issues, because I don't feel like I should be the one doing that, and there's something to be said for that too. The other question is, would you suggest taking Provigil to counter the effects of fatigue caused by primidone? I'd qualify that. I'd say I think that would most likely work, but also when you start to in psychiatry, when you start taking one medicine to counter another medicine, sometimes that's necessary, but it might be a good idea to try to see if you can modulate or try to change either the dosage or the way you take the primidone first, because they don't counteract each other. They're doing two different things, and it's maybe putting a little bit more stress on the brain. And usually, if you can avoid the thing which is causing the side effects in the first place, that's almost always a better solution. But I would guess that it would be effective, and it is used for medication-related fatigue in many other contexts.
So I have a number of questions. Try to address a few of them. Some of them actually refer again to the paper published by Prusiner on the prion hypothesis for MSA. And it's not that I disagree. What happened is that Prusiner himself showed that the prion disease, like Creutzfeldt-Jakob, is a transmissible disorder from person to person or animal to person. And in the case of MSA, Parkinson, and other diseases, there is absolutely no evidence for that. Now, it doesn't mean that the mechanism behind that is very similar. So I think what they found or what they discovered was that the basic mechanism as to how the abnormal form or the abnormal conformation of the protein can progress over time is very similar between prion, between alpha-synuclein, and other proteins. So, of course, they share similarities, but it doesn't mean that it's exactly the same. Now, on the experiment that I show you, he shows that MSA was more effective than PD at propagating the disease. But that doesn't mean that if he would have left the Parkinson go for a longer period of time, probably he would have seen the same effect. So what I'm trying to say is that there are shared commonalities in all these disorders, and the prion-like ability of propagate a bad form of the protein is one of them, and I think that that's what he showed. But where it's different is that I don't think that Parkinson or Alzheimer's or MSA are transmissible in the same way as Creutzfeldt-Jakob diseases. Now, there was also another question about a breakthrough. What would be a breakthrough that would help to all these disorders? And in a way, I think discovering a biomarker would be a huge breakthrough. I think that, and by that I mean, if we can make a scan that could see the alpha-synuclein in the brain and distinguish Parkinson versus MSA or PSP in the same way that they develop a PET scan for Alzheimer's disease now, and also they can measure certain proteins in the blood or the CSF. I think that would be a huge advancement for the synuclein field, for the Parkinson field, for MSA. It would really be a huge breakthrough, and it would also be a huge breakthrough regarding another question that I got: how many decades for clinical trials? Well, as I mentioned, there are already some clinical trials with the immunization in Europe, but these are very early stage. But really, what it has protracted these trials from advancing is that we really don't have a good biomarker, because what we want to do is that we want to start these treatments like the antibody, the other drugs, the early the possible. So having these biomarker, this scan of the brain or what have you, or a blood test that would tell us early enough that the disease is happening could really be a huge, a tremendous boost, a tremendous breakthrough.
So here's a question about pain management. Have you seen patients with MSA have success with ketamine infusions or Subutex for pain? If narcotic use has increased dosage and tolerance is increasing, in your opinion, what are the benefits, risks of each for MSA patients? So I'll say I don't have much. I'm a pain provider. I don't have any specific experience with those in MSA patients, but I'm familiar with both those drugs. That ketamine is a drug used as an anesthetic and also as a pain medication. Particularly in the operating room and post-operatively, but is also used sometimes either IV or orally for depression and for pain. It can be effective. Long-term ketamine use has some significant side effects. It can cause pretty severe bladder problems in particular, and it can also cause some and also in big doses, it can cause psychosis. So, if you're going to try something like ketamine, I'd really recommend finding a provider who's got a lot of experience with that, and preferably going with a small dose that does have the ability to reverse opioid tolerance. And so that's useful, but that ability doesn't last a really long time. So if you keep taking it after a while, it may not benefit as much. It's an area that has been under-researched, and there's actually a very big research effort on now to find drugs that would act like ketamine but would have fewer of the undesirable side effects, so that they would be safer to use. Because I'd say ketamine is not has been shown not to be completely safe, especially if you're taking chronically. Subutex is another name for buprenorphine, or Suboxone is another form of that, as a painkiller. So there is some research or some theory that drugs, Subutex or buprenorphine, may be less likely to cause respiratory suppression, so that theoretically would make it safer for MSA patients. But that's a theoretical consideration. I don't know that anyone's ever studied that. There's a real limit to how strong a dose of Subutex you can take by mouth, but I think it might be a reasonable thing to try. People will often develop a tolerance to that, just like to any painkiller, unfortunately. And I think it's important if you're having those kinds of significant pain problems to be trying other pain medicines as well, and not just taking those painkillers, because tolerance follows quickly. And if you increase the dose, the side effects can become quite severe quite rapidly, especially in people who have neurological disease.
There's a couple questions about diagnosis, or at least diagnostic testing in multiple system atrophy. One question is whether it's possible to have multiple system atrophy if autonomic testing does not find dysautonomia. And I think the answer to that is it depends on what stage of the disease. But early on, certainly, it depends on which areas of the brain are affected earlier than others. And it's possible to have more of the movement parts of the brain affected than the autonomic parts of the brain affected. And again, this is one of the things that I think Dr. Samii alluded to. Sometimes it can be very difficult to distinguish the difference between Parkinson's disease and the Parkinsonism that goes along with multiple system atrophy. And sometimes it's actually the development of autonomic problems later on that is the real key difference that we look for. So autonomic testing early on could be normal. It's not perfect. It's not 100% sensitive. People can actually have a little bit of autonomic dysfunction and still have testing values that are within the normal range. But later in the course of MSA, we would expect 100% of people to have autonomic dysfunction on testing, but early on that might not be the case. And then let me just follow that up quickly with a question about testing for respiratory problems. There's a particular question about diaphragm weakness. And I think, let me expand that just a little bit. There certainly is a concern for muscular incoordination and breathing incoordination, and that kind of muscular effect on breathing can be looked at with various kinds of breathing testing, where you're essentially looking at how forcibly you can expel air and how much air you can expel, and that's a good way to get an idea of how that respiratory function is working. There's another component that we think about, which is a central kind of a brain effect. Is particularly relevant during sleep. We're concerned that sometimes the brain gets lazy and forgets to breathe, and that is lumped into sleep apnea, but it's a different kind of sleep apnea than we usually think about, the obstructive sleep apnea with somebody that snores. This is more of what we call a central apnea, and can affect breathing as well. It's an important thing to identify, and we would like to see people getting sleep studies to be able to identify whether that problem is present or not, because it's something that can be managed.
So I'm going to switch gear back to headaches. So one question was, someone's significant other was experiencing jolts to his head, electric shocks in his head, and the question was, what was it all about? So there is a type of headache. It's called, if you look it up on Google, it's called ice pick headache. Ice pick headache. So it literally feels like being stabbed with ice picks multiple times. It's known in neurology as primary stabbing headache, and it's very, very common in people who have headaches. Any other type of headache, you can have this kind of headache, and it's very scary when you have it, because all of a sudden, out of the blue, you'll have multiple stabs, and it can feel like lightning, and it can feel like ice pick. And currently, it's thought that it's caused by just increased neuron excitability. So kind of first sign of the brain kind of perceiving something is wrong. Usually it's benign, meaning it's not caused by cancer, multiple sclerosis. It doesn't mean anything horrible is going on. It feels horrible, but it's not caused by something bad. And usually it's treated by melatonin at night. The other medication that can be used is indomethacin. However, indomethacin is hard on most people's stomachs, and it turns out that the melatonin mimics the indomethacin. And so you would take it at night, just like a sleeping potion for sleep, and over time it can decrease the jabs and jolts. Also, the same way you increase your serotonin, you increase your melatonin. So in many of these patients that I see, we recommend going outside early in the morning. Yeah, the same way we've talked about increasing serotonin levels could get rid of their ice pick headaches, or again, they're known also as primary stabbing headaches. So that was one question. The other question was regarding to treatments. So there was someone's spouse who was taking topiramate, Topamax, and they were having some issues with sweating. It's not a very common thing seen with Topamax. Much more commonly, sweating can be impaired with sometimes nortriptyline. So medications that affect noradrenergic system, specifically noradrenaline, can have impairment sweating, but it's very, very rare that you see that. So if you think it's from topiramate, I mean, obviously you would want to discontinue it, but it's not something that I have ever seen with topiramate. I have seen it with other medications, but again, very, very rare side effects. So topiramate shouldn't be an issue for an MSA patient. The other question was that someone was getting dopaminergic medications and they increase headaches. And so one of the slides that I have listed was, I don't know if you recall it or not, but it was that the neurotransmitters change during the migraine. And before migraine, usually you have decrease of the serotonin and noradrenaline, and you can have increase of dopamine. So we don't know if the dopamine increase can then cause the headache. So in certain people who are sensitive, certainly could be this piece. The other piece would be there are other things that the dopamine or dopaminergic medications can cause, such as decrease in blood pressure. And if you have abnormalities in blood pressure, it can certainly cause a headache as well. So you would have to evaluate and specifically for that person, what is happening? Why is it that, you could measure the blood pressures with the medication, see, am I affecting it very significantly? And kind of the last to address was craniosacral therapy. Would that be helpful? So I'm just going to tell you, chiropractic therapy, yes, it fixes you, but it doesn't permanently fix you. So the problem for people are if you're not exercising and then maintaining what the physical therapist or chiropractor helped you achieve. So if you don't strengthen the muscles, you're wasting your money on craniosacral therapy because all you're doing is, yes, they'll help you, to get you to the normal position, and you might stay there for a few minutes or a few hours, but then your body, because it's weak, goes back to its original position. So unless you combine these kind of therapies, physical therapy and craniosacral, with the exercising, it's really not that helpful or useful.
Thank you. I got more questions again about the Prusiner paper. And again, I just want to, and I also had a question about if it's transmissible through instruments, like surgical instruments. Again, as I mentioned before, I mean, we don't know, but there is no evidence, and I think it's very, very unlikely. Again, I don't think it's like Creutzfeldt-Jakob disease. They share something, but they are very different in other aspects like this one. I don't think you should be concerned about if you use scissors or some instrument or something and that you can get contaminated. I don't think it's the case as with Creutzfeldt-Jakob. I also had a couple of other really interesting questions. One I want to address. The question is if the lentinerosin can be used to infect ex vivo mesenchymal cells. And this goes back to what I was talking at the very end. I think at the end of the day, we're going to have to combine some of these therapeutics. And for example, as we heard before, the mesenchymal stem cell transfer is being tested right now at the Mayo. There is some promise, but we still have a long way to go with this. But here is one problem. The environment in the brain in a patient with MSA or Parkinson is not favorable for those grafted or transplanted stem cells. So they might work for a while, but eventually they are going to stop working. So if you actually confer a defense mechanism to that stem cell, so you put in the brain a stem cell that could actually defend itself from the environment on that brain, actually it's going to make it more likely to survive. And I think a therapeutic like the stem cell would be more viable if you combine it, for example, with neurosin. I think that's an excellent idea. I got also another question about the availability of the antibodies from Prothena. And again, these are still in phase 1 clinical trial. And I don't think that they will become available for MSA for a while until the PD clinical trials will be completed, and that probably will take a few years. I actually also got a question about how long does it take for these clinical trials to complete. But yeah, it still will be a few years, and I don't think that these antibodies will be made available for MSA, even as I am asked here as a compassionate use. I think it's very unlikely that that will happen until the testing on Parkinson's disease is completed. But we hope that some of the other antibodies that are being developed and some of the other biological strategies that are being developed, again, like the stem cells, like the neurosin, hopefully might become available sooner rather than later.
I had one more question I overlooked about executive function. Could you give a little more info about executive function, why MSA patients have issues with it, and whether anything can be done to help? So just when they talk about executive function, sort of as I was talking about in my lecture, that whole process of thinking about your situation and deciding what's the thing I should be doing right now, and then executing it. We all do that all day. All of us do that all day long, and everybody knows that there are times when it gets harder, especially for example, if you've got a small child. If you're taking care of a small child, it can be hard to even keep anything else in mind except keeping that small child safe and away from the firearms and stuff. So you can. Why MSA patients specifically have that? I think it's. I don't want to sound boring, like say things are multifactorial, but executive function is really. I mean, it's a pretty complex. It's pretty complex. I mean, it's almost like talking about behavior in terms of it's one of the main things that humans are really good at, right? We're much better at that than chimpanzees. That we can form a plan and stick to it for days or years if necessary. We're really good at it in general. But it takes a lot of different areas of your brain all working together pretty nicely to do that properly. And I think the autonomic dysfunction that we've been talking about, I think that has a role to play. Cognitive the kind of generalized cognitive impairment that's common in MSA later on makes it more challenging. And I think also the basal ganglia. A lot of times when we talk about the basal ganglia, we'll talk about them in terms of facilitating movement, like in Parkinson's, but actually the basal ganglia are they're also pretty involved in behavior. And if you put someone in an fMRI machine and you ask them to plan to think about how they would do a dance step, for example, or how they'd hang a picture on the wall, either basal ganglia will light up as they work out the steps involved in picking up the picture and holding the picture in one hand and pinching the nail between their fingers while they swing the hammer with the other hand. There's a whole bunch of things that you have to do, and you have to get them in the right order, or the picture, or it's going to be a huge mess. And that's a complicated thing. And those basal ganglia, when that dysfunction, I think affects that as well. As far as whether anything can be done to help, I think some of the best things are trying to avoid things that hurt it. So, and some of that is just things like stress, fatigue, deconditioning. When we talk about stress management, I mean, I don't want to make it sound like stress avoidance. Stress avoidance is kind of impossible. We're trying to toughen yourself up to stress. So for some of the patients in the chronic fatigue clinic, they have a lot of difficulty with the executive function with them. Sometimes doing things like mindfulness meditation or relaxation techniques can be pretty helpful, because both of those are things which tend to calm down the brain. They tilt the autonomic nervous system more towards the parasympathetic side of things, and often that will help calm people and allow them to sort of think things through better. And another thing that I think is helpful is to keep in mind that you have a limited amount of brain power that we all do. And if you look at some of the most talented people in the 20th century, Albert Einstein famously only wore one kind of outfit all the time. He had a closet identical suit. So I don't know. Maybe he didn't, but it's a great story. Ingmar Bergman, the Swedish movie director, would only had one meal that he would eat every day for lunch when he was making a movie. So if it took 200 days, he'd eat 200 of the same lunches. And someone asked him why, and he said, I don't want anyone to ever break my train of thought to ask me what I want for lunch. So those guys were onto something, because it turns out, and there's plenty of, this kind of comes from the field of behavioral economics, but every time we make an executive decision, and every time we exert willpower, we're actually tapping into a finite resource, and it gets replenished. There are things you can do to replenish it, but especially if that resource is already getting challenged, finding ways to simplify things can actually help quite a bit. So, maybe don't be like Einstein and let your hair go wild and wear only one kind of suit for the rest of your life, but finding other ways to simplify things and not make ad hoc decisions all the time, that actually can free up quite a bit of brain power for the more important stuff in life. And then all the medication, some of the medications we talked about too, there's evidence that they can also help strengthen prefrontal function. There's not a lot of evidence that doing things like Sudoku or the Lumosity that you see on the internet, those brain exercises, not a lot of evidence that those really help, but I don't know any studies of them in MSA.
Well, there's one question about the management of high blood pressure at night, and this really can be a problem because most of the medications we use for high blood pressure actually last a long time. But there are some that you can use short-acting. Some of the calcium channel blockers, amlodipine, or smaller doses of some of the short-acting drugs such as diltiazem can be used, especially if they're taken earlier in the evening rather than late at night before you go to sleep, so that their effect is essentially worn off or almost completely worn off by the time the morning comes. Sometimes people have used nitrates, which is not a drug we commonly use for treating hypertension, but because it can be used as a short-acting medication, sometimes that can be helpful also. Some of the other common drugs like lisinopril, which is an ACE inhibitor, or something called an ARB, losartan. Sometimes very small doses of those, you can get away with using them for people with very severe hypertension. So it can be quite a challenge, but you can sort of work with it and then also continue people on their daytime medications, such as midodrine-hydroxydopa. There's some off-label uses of mestinon, which is a drug for myasthenia gravis, which probably has less of an effect to cause supine hypertension. So that can also be an option for people who are very difficult to manage.
Great. We have a couple questions that I think are interesting, and I'll maybe mention something clinically, but we might want to get some opinions from a research perspective about theoretical implications of this. So a couple questions about whether certain types of injury to the nervous system might in some way be a trigger or contribute to multiple system atrophy. Specific question about traumatic brain injury, and I don't think we have evidence for that, but in some ways I think it would be interesting knowing that inflammation is involved and accumulation of normally intracellular proteins like alpha-synuclein are involved. Theoretically, is there a reason we should be looking for this? Is this something we could have missed, or is this really maybe not part of the pathogenesis of MSA? Do you have any thoughts on?
I think that, well, there is some genetic evidence that multiplication of alpha-synuclein, there is a patient with multiplication of synuclein. Oh. Hello? Hello? Oh. Hello? Hello? Yeah. Yeah, I was saying that it's probably a combination of genetics and environment. The genetic factors, there is a case of a patient with a genetic abnormality on alpha-synuclein that developed MSA. And then there are a couple of other cases on genetic abnormalities and other genes, like, for example, genes associated with ALS, interestingly, and other things that were manifested pathologically as MSA. But yeah, environmental factors also, pesticides, toxins. So probably it's a combination, right, of environment and genetics. But there is nothing really as solid as what we have, for example, for Alzheimer's or Parkinson's disease. They're still unclear. But I think the fact that and I think some of you referred to the story of the coenzyme the Q2 in Japan. I mean, that could indicate that, again, there is a genetic base that could also interact with the environment.
Yeah, so to answer also the question, so how we're starting to think about most disorders is that there is always certain genetic predisposition, and then you have the environmental stimuli. So someone who, let's say, has a very strong genetic predisposition, nothing environmentally necessarily has to happen, and they might develop the disorder. On the other hand, in people who never had very strong genetic predisposition, then things like trauma could matter much more. If you have someone who has genetic predisposition and trauma, then it might be much stronger. It could be that final trigger that turns the genes on to start expressing themselves. And so a lot of the neurodegeneration has to do with aging. So certainly we don't really understand that clock, and maybe Dr. Mosvik can answer that. But aging certainly has something to do. That's why you can see Alzheimer's, Parkinson's much later on. You very rarely see it unless there is certain very strong genetic predisposition in younger patients. So, I get asked that question a lot with trauma because as a headache expert, I see a lot of people who never ever have headaches, and then they have trauma and boom, they start having headaches every single day. And so you can certainly trigger genetic expression of something that you've never would have had if you didn't have trauma. So the question is then, what can you do about that information? And that's a different story.
I have a quick question for Dr. Masiad. This is related, more scientific, but there's a well-known clinician, Dr. Nadegaard, who has been researching what she describes as the glymphatic system, which is sort of the flushing system of that helps clean out what you might call toxins from the nervous system. Involves spinal fluid, and particularly during sleep. And she feels like this may be important in other accumulation diseases, beta amyloid particularly. Do you think that there is any reason to think that this could be important in an alpha-synucleinopathy like MSA? Is it something that should be looked into in some way?
Thank you. Yeah, interesting, because I also got a question about the new discovery of the lymphatic system and what are the implications. So, yeah, no, I completely agree with you. I think that if it's another clearance, another disposal clearance mechanism, and synuclein actually goes through the glial lymphatic system and could be cleared through the CSF. So if there are defects, especially during the nocturnal versus diurnal cycles in that mechanism, definitely there could be a problem. In fact, we have measured the levels of synuclein during late night and, during different times of the day, particularly in our animal models, and definitely at night, there is more alpha-synuclein accumulating in the brain. And it's sort of like as if the glial lymphatic system is less efficient, probably got to do with circadian cycles and so on. But definitely, I think it's very important.
Are there more questions? Okay, I think that was the very last question, coming from our panel, no less. So I once again want to thank all of the physicians, and Dr. Oakley, a special thanks to you for, I think everybody always pulls a new piece, even if it's not absolutely new information. They look at it a new way or can absorb a little bit more of what's happening. So we really appreciate that. I have a couple closing remarks. Our videographer, who's followed us for 4 years, Alex, you and Scott want to kind of wave over there. They actually did a conference for us in 2012 in New Jersey, and they've come and they followed us ever since. We keep inviting them back. And I'm sorry, we had another photographer here. Huh? Jason. Okay, thank you, Jason. I've not met Jason before. Yeah. So, if you see extra binders or tote bags laying around and want to take one to a family member or something, or a binder for, a family doctor, somebody who might need to know a little bit more about MSA, feel free. I mentioned before we have DVDs of last year's conference that are free. We're selling, there's money here, folks, T-shirts for $15. And I think usually we pick a place for a conference in the late spring, early summer, and we work around like crazy. But I am happy to announce that we already have next year's conference site picked out. We already have a group of physicians or a physician to be the head host physician. It is going to be in New Orleans in October 14th and 15th. Dr. David Houghton, I think it is, Houghton. I'm not sure I'm pronouncing it right. With a southern accent, it might be Houghton or something. I'm not sure. But it is Houghton. All right. See, my southern roots come out a little bit. But anyway, thank you all for coming. If you can join us next October, and you all are invited back as guests to sit in. Yeah. And as I said last night, for those of you who weren't there, Erin Williams, you want to stand up again, Erin? Her mom is here as a patient. She's here as a devoted daughter who wanted to do more for MSA, so orchestrated our Friday afternoon sessions. We did not have a lot of publicity out on our website because that was a new adventure for us. But I think we're probably going to include similar stuff next year. So thank you very much. Now, the last thing on the agenda is patient caregiver breakouts. We had those yesterday. We are willing to stay. We've got this room for about 20, 25 more minutes. If somebody wants to do a brief patient breakout and caregiver breakout, we're willing to stay. So we'll hang around for a couple minutes. And safe travels back home if you're staying in Seattle. Have a good trip. I'm staying until Wednesday, so I may look for you guys. Thank you. We really appreciate all that you all have done. We may not be the most organized group in the bunch, but we do appreciate it. So thank you.
Lymphatic system not working.